Our next speaker is Dr. Jay Jung. Dr. Jung receives her training from Washington University, St. Louis, and then went on to do, at that time, she got her MD and PhD from WashU, and went on to do internship and residency in dermatology, also at Washington University. And then from there, she went to City of Hope in California, where she was a faculty member there and focused in dermatologic oncology. And we were fortunate to have Jay come to us to offer this important specialty to our patients. And I always hesitate in this one because I know for a fact that she will show some very alarming pictures just to make me uncomfortable. But please welcome Dr. Jay Jung.
So this set of photos, sadly, sorry, Joe, are even more unpleasant than my usual low standards. Yeah. So thank you again for inviting me here to speak. Today, in honor of our keynote speaker, I wanted to focus on something that we see relatively commonly in our clinic, although it is rare in the general population. And this is cutaneous malignancies that occur on genital skin. Here are my disclosures. This is gonna be like a case-based discussion, so I will go ahead and get started. The skin is our largest immune organ. It has, a lot of antigen-presenting cells. It has resident memory T cells. The Langerhans cells in particular are a very important part of processing antigens so that our immune system can recognize it. And these are very, very important ways for our bodies to fight not only infection, but fight cancer. And this is what the checkpoint immune inhibitor kind of revolution has done for malignancy treatment in general, and really has started to make inroads on some difficult cancers in the genital area as well. So before I get started, I want to tell you about kind of the three workhorses that I have in dermatology. Liquid nitrogen cryotherapy is one of them. It is actual liquid nitrogen that is in that canister, and it gets pushed out through a nozzle. The repeat freeze-thaw cycles rupture the cell membranes, and it really causes these danger signals, the first responders of the immune system. You can see here this patient is urticating at each site. And what this does is it helps to not only kill the tumor cells, but it allows those, or like pre-skin cancers essentially is what we treat them with. And it allows those cancer antigens to then be taken up and then be processed into more effective, resident memory T cells and then targeting T cells. I'm not going to go into this paper extensively, but I just wanted to highlight the benefit of the cryo part of this, like the freeze thaw is much more effective mechanism for generating good, valuable, recognizable cancer antigens than things like radiofrequency ablation or heat ablation. And in this very controlled model of dendritic cell loading, you can see that the cryotherapy was much, much better in terms of developing good cancer antigens or antigens that are able to be loaded by dendritic cells, which are then able to be recognized by the rest of the immune system. Topical fluorouracil is a chemotherapy cream. It is FDA approved for actinic keratoses and superficial basal cells. And it's generally prescribed as a topical cream. We apply it for 2 to 4 weeks. I enjoy prescribing this cream as kind of a first line because it has a very, very predictable response. They get irritated in 4 to 5 days. And, by 10 or 11, they're calling Tina to complain that their face hurts, and then 14 days it's over and then they heal. And this gentleman, you can see, did kind of a field therapy, so this is great for patients who just have background actinic damage. It is very effective. They always look great. People always want like his wife wanted it, right, because they thought it was more of it almost looks like a chemical peel. Here is the same type of thing with squamous cell, like even in very superficial squamous cells, we can have excellent results with topical fluorouracil. And then the other workhorse that I use for topical therapies is imiquimod. This is a TLR7 agonist, and it is in the pathway of recognizing viral infections, and it gives you a very brisk inflammatory response. This cream is approved for actinic keratoses, superficial basal cells, and interestingly, genital warts, which I use it for less commonly than the others. It is generally applied at 3 times per week, and it's applied at night. But this one, because it activates the immune system, it is really unpredictable how it will work. Some patients, I had one gentleman who was like in his 90s, put it on, and he got immediately ill. The whole area got swollen. He even had a low-grade fever. And some people will put it on for 2 solid weeks and they won't really get a response. So it's a little bit unpredictable. Here is a gentleman that I treated. He refused surgery. It was multiple recurrent basal cells, as you can see, on his head and neck. And this was after about 8 weeks of treatment, and he had a complete clinical response. So case number 1 is vulvar intraepithelial neoplasia. This is a female patient who has a long-standing history of vulvar lichen sclerosis. It was initially diagnosed in 2002. She had numerous surgeries, as these patients often do get, with ultimately a vulvectomy. She also had laser ablation, but unfortunately, scouting biopsies showed extensive areas of VIN. And just to briefly talk about the VIN subtypes, there's the usual type, which is associated with HPV. Younger patients, histologically looks more warty or basaloid, and clinically multifocal. The differentiated type, which this patient had, is the one that is associated with chronic inflammation, things like lichen sclerosis, lichen planus. Sjogren's also can do this. It has a higher oncogenic potential, increased risk of progression, older age in the patients, and the treatment options for both of these are similar. Generally, surgery, laser ablation. Unfortunately, there are no topical therapies that are FDA approved, but I do like to use them in patients who are reluctant to undergo surgery. And we will look at that next. Brisk inflammatory response. So this is, we start with topical 5-FU. I ask the patient to do twice a day for 2 weeks. We tend to do 2 weeks at a time because in my personal experience, that's kind of as much pain and discomfort as a patient will tolerate before they stop using it anyway. So we do 2 weeks at a time. And then it is really critical to include good wound care as part of this. Obviously, this is a sensitive area and it's very uncomfortable. So we do a lot of combination topicals, mupirocin, gentamicin, ketoconazole. Triamcinolone is a topical steroid, and it's very important, even though it's counterintuitive to add a steroid to that area. The the inflammation that kind of drives the underlying lichen sclerosis or lichen planus will make it very difficult for that area to heal. So the addition of topical steroid is actually very important. We also love using Xeroform gauze and, of course, topical lidocaine to make it more comfortable. And here you can see she's had a quite a brisk inflammatory response with a lot of erosions. And here she is, essentially had a complete clinical response for about 3 years. She had some flares of her lichen sclerosis, which was treated with topical steroid, but the neoplastic part did not really recur until recently. She came in with recurrence, but we just repeated, the surgery at this point would be quite morbid to do. So she opted for another trial of the topical 5-FU. And again, she had a really great, response with really minimal symptoms after this second round of topical 5-FU. Here is a case of extramammary Paget's disease of the vulva. This is a rare cutaneous intraepithelial adenocarcinoma. It involves primarily the epidermis, but it can invade into the dermis. These are really itchy plaques that are on the vulva most commonly postmenopausal women. And it is very frequently misdiagnosed because, they're postmenopausal. A lot of times they're a little bit obese. A lot of these get mistakenly treated as fungal infections for a long time, et cetera. It can also be seen in men involving the penis, scrotum, and perineum as well. Unfortunately, the treatment options for this are surgery and or radiation, but extramammary Paget's has this tendency to spread just beyond where you just treated it. So a lot of times patients are getting this kind of whack-a-mole surgery where they do one excision, it comes back at the margin. They'll do radiation, it comes back at the margin. So it is a very frustrating type of malignancy to treat. And it just kind of crawls over the surface. So it's not very deeply invasive, but it's over some really important functional parts of your skin. So after some discussion, this patient is very, very anxious and really just was not looking forward to any kind of surgery or radiation. So we opted for a trial of topical therapy. We started with imiquimod, and because the inflammation is a little bit unpredictable, we started with 3 times per week. They come in packets because they were designed for genital warts. They didn't want it cross-contaminated. So I tell patients do not use more than 1 packet per day. And then if they get it's more of a titration to kind of a mild, moderate inflammatory response, because it really is hard to tell who's going to react really briskly and who won't. If there's a really brisk inflammatory response, I have them reduce it to 1 to 2 times a day. And if it's an inadequate response, I'll even increase it to 5 times a week. And here you can see she's starting to get that inflammatory response with more redness and irritation. Again, good wound care. A lot of these patients, she in particular had, a body habitus that made it very hard to do good hygiene. So, squirt bottles by the toilet, a lot of these patients who have irritation for some reason love those prepackaged wipes that have so much fragrance and preservative in them and just make everything worse. So I tell them to take all of that out, fragrance-free, dye-free personal care products, just pat with paper towels, squirt with, just all the gentle things. And then, of course, the wound care comes into play as well. And you can see she's had really an amazing clinical response. It took a long time, and she was very anxious through the whole thing. But, ultimately we got her to a complete clinical response. And she was worried a little bit about long-term side effects of being on this. And we had already been on it for 9 months. So she wanted to stop. And unfortunately, it came back. So now, and we tried to redo kind of the whole thing, but it's now become largely resistant to topical therapy. I do wonder if we kept her on a maintenance, would it have stayed away? I don't know the answer to that, but now she has moved on and is considering surgery, although she, because of her anxiety, is definitely dragging her feet. Here's another case of extramammary Paget's of the vulva. She also opted for a trial of imiquimod. This was also started with 3 times per week. She actually had a really good brisk inflammatory response. Her course was complicated by a lot of incontinence and need for a pessary and, a lot of wound care and hand holding. But she ultimately had, sorry about the poor quality of that last picture, but she had really a complete response, really minimal irritation by the end. And now she only comes back to see me, once a year to just kind of check to make sure that nothing has recurred. And then moving on to penile skin cancers, we see this not infrequently. This is a gentleman who came in to see me, obviously not really thrilled about his surgical options. The urologist really only offered a penectomy. We discussed radiation, but you can see around because it involved the area around the urethra, they were worried about scarring and, potentially having ureter dysfunction. So he opted also for do like to use cryotherapy in addition to topical 5-FU, because a lot of times especially the skin cancers in genital skin will develop a cornified layer over it, which kind of prevents water and things from getting in, and it'll prevent the 5FU from getting in. So a very light cryotherapy to the top allows more even absorption of the cream. And here is a good inflammatory response after 2 weeks. We did an additional week to make sure that everything was treated. And the macerated part is his biopsy site. And here he is, a complete clinical response after that 3 weeks, and he has had a really long lasting remission from this. Here's another penile squamous cell carcinoma. This one is an in situ. This patient has B-cell lymphoma, was in remission. He recalls when he was in the hospital that the area became really, irritated, and everyone thought it was a, kind of a chemotherapy reaction where they get erosions in the genital area, but it was persistent, and the biopsy demonstrated squamous cell carcinoma in situ. And again, we used cryotherapy plus topical 5FU, and he has had a sustained remission now for 2 years. All right, thank you very much. Those are my cases. And when I'm not working, I am here at Disney World.
Any questions?
Any questions?
I do have so for those that aren't specialized in this area, what is your thoughts around when do they refer to you versus going to general dermatology? I know you see a lot of patients that are cared for a long time that have these types of diagnoses. Maybe give some advice on how best to connect with you.
So I think that, in general, most dermatologists will take care of most like skin cancers and things like that. But unusual sites like the genitals definitely they're less comfortable with dealing with. And one of the big problems is that these topical therapies are not really FDA approved for these indications. So it takes some, risk benefit discussion and, kind of a understanding that this is maybe not the gold standard for the disease, and a lot of general dermatologists aren't comfortable having that conversation. So I am happy to see them in cases like that. All right, thank you so much.
So our next speaker is Dr. Don Stevens. Dr. Stevens graduated from Georgetown College in Kentucky and then did his medical school and residency at University of Louisville and fellowship at Johns Hopkins University in Maryland. Don's our leader of our hematologic oncology program and really has been prolific. He speaks nationally, had multiple publications, including New England Journal of Medicine. I think he set the standard in this region for how do you advance hematologic malignancies, and we're really honored to have him as a colleague and friend. And he's going to speak today on multiple myeloma updates and reviews. So Dr. Stevens.
So what I'd like to do today is talk to you a little bit about some updates in myeloma. This is a relatively rare disease that accounts for less than 2% of all malignancies in the United States, probably somewhere in the order of 20 to 25,000 new cases every year. However, we've seen really an explosion, thanks to the work of our research department. We've seen an explosion of new agents for this and new approaches to treating myeloma. In the past 10 years, for example, the 5-year survival rate has more than doubled, like 2.2 times what it was 10 years ago. And that's, again, thanks to clinical trials. So I can't say that enough. So a brief history, my objectives. So to understand the rationale and options for first and subsequent lines of therapy, to understand the role of cellular therapy, understand the role of drug-target interaction, specifically some drugs that are sort of like IMiDs, but even better than IMiDs, and we'll go over that in some detail. And then lastly, finish with the importance of including a diverse population in clinical research. So just a small bit of history. I think this is worth 30 seconds. Starting in, and it's clearly the first patient, Thomas Alexander McBean, was a grocer in London. He was visiting and vacationing in Scotland in the fall of 1844. He had a slight jump on a trail or a hike he was on, developed excruciating chest pain, and then went back to his doctor in London. He sent him to a couple of subspecialists. They could never figure out why this guy was in so much pain. He was losing weight. Finally, they submitted his urine to two doctors, Dr. McIntyre and Dr. Vince Jones. This is the Dr. Vince Jones that we call the protein in the urine. And they thought for a long time that it was albumin. They really didn't know anything about immunoglobulins. So on the cause of death, when Mr. McBean died, they listed it as atrophy because he had complete muscle wasting. His bones were shot. But in 14 months later, he died on New Year's Day in 1846, and they listed the cause as atrophy secondary to albuminuria, that they thought he was just wasting too much albumin. It wasn't for decades later that we learned the concept of really what multiple myeloma is. In fact, the first effective treatment was in 1958, and that was melphalan. Now I'm going to fast forward 175 years, skipping all of the other history, including, remember, we didn't do bone marrows till 1929. So a year after Charles Lindbergh flew over the Atlantic in a solo flight, that was the first time that we were actually sampling bone marrow. So definitions of smoldering, I think this is worth talking at almost every myeloma talk. I think it's important to know when we treat and when we don't treat. We draw that line at smoldering versus symptomatic or consequential myeloma. I'm not going to go over the details here, but we have very well-established criteria for when to initiate therapy and when these patients can be followed with observation. That's listed on this slide, and I won't go into the details in the interest of time, but did want to show this to you. Also, we can look at risk stratification for newly diagnosed myeloma. Disease that has, again, this international scale of 3, extramedullary disease or plasmacytomas, high-risk gene expression profile, which we don't typically do in community-based practice, but that is becoming increasingly important and more available to our pathologist. For relapse myeloma, if the relapse is less than 2 years, that's clearly not good. Relapse within 18 months in case of a non-transplant-based therapy. And if you begin to acquire additional genetic mutations, some of these tumors undergo clonal evolution, and they get more and more mutations and behave more and more aggressively. So again, this does not project well, but I did want to just share with you a couple of things. This is from NCCN. When I was in training as a resident, the first edition of a comprehensive cancer medical textbook came out. The first editor was DeVita. DeVita's Principles of Cancer Treatment was published initially in 1979. I went back and looked for this talk. I looked at my first edition of DeVita. There were 30 pages on myeloma, about 3.5 pages devoted to actual treatment of myeloma. Now the NCCN guidelines, if you print them out, are 140 pages. That would be worth an ooh or an ah, at least, I think. I know it's not a picture like Dr. Jung shows. So this, the one category, so we still, in newly diagnosed myeloma, we separate patients that are going to go to have a consolidation with transplant as part of their first line of therapy, and those that are not. For those that are RVD, the 3-drug combination is standard of care. There are occasions in our tumor board, Dr. Malley and I will recommend 4 drugs with adding daratumumab, the monoclonal antibody against CD38. But RVD is the standard of care. For patients that start out with renal dysfunction, we will sometimes use cyclophosphamide instead of lenalidomide. But the NCCN does recommend, and I would as well, that once the renal function is improved, or if it improves to a point where you can add the lenalidomide, that is the best thing to go back to the RVD. For patients that are not transplant eligible, then there are 4 different category 1 options, including a melphalan with 3 other drugs, daratumumab, et cetera. So again, lots of different options about what to do with both patients that are going to transplant and those that are not. I'm specifically not going to address today what role transplant has in 2023. I think it's evolving. And I think that in the future, there will probably be fewer patients going for transplant. Remember that autologous transplant, while it is quite effective, and there are now multiple publications showing that it prolongs disease-free interval, there are no publications that show that it improves overall survival. The reason for that, of course, is that there are so many 2nd, 3rd, 4th, 5th, 6th, 7th line therapies available. So how do we decide when we're talking about 2nd-line therapy? What do we choose? Well, we can look at the duration of response to the last regimen, the mechanism of action. We can recycle things that we've used before, or we can use novel mechanisms of action. The toxicity, including financial. Some of the drugs we use, of course, are horribly expensive and are not uniformly available to everyone. So the patient's cost or out-of-pocket cost is a consideration. And then convenience. Some of the regimens that are listed in the next couple of slides are all oral or basically outpatient. Some of them require frequent visits to the office. So that's a consideration as well. Again, I'm not going to go through all of these in detail. We don't have time for that. But just to tell you that we have multiple, for example, in this first slide here, there are multiple category 1 recommendations. As you can see, multiple different combinations. Also bear in mind that just because someone has progressed, say, with lenalidomide, there's still about a 30% chance that they will respond to pomalidomide. So once you don't necessarily have to switch classes of drugs, especially depending on the duration of response to the lenalidomide. There are some regimens that are specifically for aggressive disease, and these would be drugs like DT-PACE or regimens like DT-PACE or hyperfractionated high-dose cyclophosphamide. We have some very novel things which we'll go into in greater detail in the next couple of slides. I'm not specifically going to mention these. Dr. Malley just mentioned to you bite therapy. I'm going to leave that to Dr. Champion, who's going to address that in a few minutes. But I am going to spend a few minutes talking about the cellular therapies that are available for our myeloma patients. Also wanted to mention selinexor, which is an oral drug. It has that advantage. It does have some toxicities, specifically GI, but those can in general be managed. And all of the treatments on this slide, for example, are for people who've already failed 4 other regimens. So again, impressive that we have these options. I want to talk about a new drug. This is mezigdomide. Mezigdomide, as you might imagine, since it rhymes with lenalidomide and thalidomide and pomalidomide, is related to that. And it is a drug that this was recently published last month in the New England Journal of Medicine. Just a brief before we go into this new drug. Remember, just to recall, thalidomide was a drug that was removed from the US market in the 1960s due to the fact that it's so teratogenic. But it never completely went out of production and has been available in other parts of the world since then. In the 80s, it was thought that because of how this drug worked, that it might be useful in leprosy. So it started having its bounce back, if you will, in treating leprosy. And then because leprosy has some things in common with graft versus host disease, when I was a fellow, for example, we actually used thalidomide to treat chronic graft versus host disease. It was not available in the United States, but someone had the ability to sort of smuggle it into the United States, and it worked well for our patient, as I recall. In the 1990s, it was felt again, based on just how that we thought this drug worked, it would work in myeloma, and it worked quite well. And these drugs, lenalidomide and thalidomide and pomalidomide, were approved for myeloma, but we did not know the mechanism of action. This is one of those rare situations where the FDA approved the drug based on the empiric results. We were actually helping patients with myeloma, but we didn't really know how the drug worked. There are all these vague hand-waving things like it was an immune modulator. It was anti-angiogenic, but we really didn't know until basically the past 5 to 10 years. And I'm hoping that this projects somewhat well. In the top, you can see that the two drugs, how these drugs interact with a molecule called cereblon. This is a drug that's very important in protein catabolism. You might wonder, the protein, once you make a protein, does it live forever? It does not. It undergoes a catabolism and breaks down. So what happens when you give these drugs, these IMiDs, and this new drug, is that it binds to the cereblon, and then that causes the cereblon to create what are called neosubstrates. And these neosubstrates, specifically Icarus and azulose, are transcription factors inside the plasma cell. And the plasma cell can't live without them. And so if you give a drug that changes the machinery inside the cell that's responsible for protein degradation to attack these transcription factors, then the plasma cell dies. And that's how these drugs work. In the bottom left, you can see that, and again, I'm sorry, this doesn't project better, but in the bottom left, you can see that only when the cereblon is closed does it cause protein degradation. And in the new drug, this mezigdomide, that it basically has 100% of the cereblon closed, which means that there can be less cereblon in the plasma cell, and this drug can still be fatal to the myeloma. So this was a recently published trial, as I said, last month. These are the patient characteristics, which I won't spend a lot of time on. I'm running out of time. I did want to point out one thing, which we'll come back to in just a few slides, which is there were very few non-white patients in this trial. One of the things I'm proud of, and again, we'll come back in a minute, is the diversity we have in our myeloma studies here at Norton's. So 100% of these patients were exposed to previous IMiDs. They were all basically refractory to lenalidomide and pomalidomide. This is a slide showing how well the Aiolos levels go down after treatment. On the right portion of this slide, you'll see a photomicrograph looking at stains for this transcription factor. On the left is at screening. On the right is after 8 days of treatment. So after 8 days of this oral drug, you can see almost a complete disappearance of this transcription factor in the myeloma cells. Again, in the interest of time, I want to quickly go over the CAR T therapy. This is cilta-cel, and this was a versus standard of care. This is an anti-BCMA or B-cell maturation antigen CAR T therapy. This was 419 patients randomized. This was published in July, just this past summer. Wanted to point out a couple things. The progression-free survival at 12 months was 75% with the cellular therapy, 48% with the control. The complete remission rate with cellular therapy for this heavily pre-treated group of patients was 73%. Not unexpected, there were cytokine release syndrome, which Dr. O'Malley mentioned a moment ago. But this, while it was very common, severe cases were very uncommon. So all cases of CRS was 76%, grade 3 or higher was less than 2%. I did want to mention the other products that's available were ide-cel, again, compared to standard of care. This is 386 patients, a 2-to-1 ratio. The median progression-free survival was 13 months compared to 4 months. So it's a definite role for cellular therapy in myeloma. And again, these are the progression-free survival curves. You can see the difference here. This is not the only target we have. We also have another target for cellular therapy, this G protein receptor coupled 5CD protein. This protein is on the myeloma cells and can last even in more advanced cases of myeloma. One of the problems with using BCMA is that that antigen can be lost as you continue treating the myeloma, especially if you target it. So elrantinab is another BiTE therapy. Elrantinab is a study that we've had here. I cannot show you the data because it's still embargoed by ASH, but this is an abstract that's been accepted for presentation at ASH in December. And specifically, this was an ad hoc analysis looking at African-American or Black patients in this clinical trial. And again, I won't read this to you, but basically this is an issue because in general, in myeloma studies, the African-American population is underrepresented. And in fact, I'm proud of the fact that in at least one of our studies, we had more diversity. We had more patients, non-white patients, than in the general population in the metropolitan area. So I was pleased with that. These patients were heavily pretreated. Conclusion is that it has good clinical activity and safety. This is a slide I used to use a lot when I did transplant, which I thought, it kind of summed up the fact that diseases are so desperate, you have to have a transplant. So I'm really hopeful that in multiple myeloma, that in the future, that we will not think of these as desperate times, desperate diseases. And so we will not have to follow the advice of Hamlet's fratricidal uncle turned stepdad who sent him off with Rosencrantz and Guildenstern to take a short cruise. And again, 175 years after the first sick English grocer, we're doing much, much better with myeloma. And again, research. Thank you. That's it.
Any questions for Dr. Stevens? I will ask, so for patients, Black patients have double the chance of having myeloma, and they typically diagnosed 5 to 10 years earlier than their counterparts. What do you suggest? You did a great job in accruing to clinical trials. What do we need to do more as a population of clinicians to ensure that we're not only giving access to care, but clinical trials for people of color and minority groups?
Yeah, that's a great question. I really applaud Norton for having a major emphasis in healthcare equities. I think that's the starting place. And then after that, it is trying to demonstrate to patients that, hey, we have something novel. We have something that works differently. And because of our research program, we have the ability to offer that to you here. And I think, again, addressing health equities is the first step, and then having access to clinical trials is the next step. Thank you. Thank you all very much.
All right. So our next speaker is Dr. Chandler Park. Dr. Park is our expert in genitourinary malignancies and has very storied career in doing a lot of things in support of not only this disease, but across certainly the state. He's a native of Kentucky, grew up in the Fort Knox area. His dad was in the Army. Chandler served as the president of Kentucky Society of Clinical Oncology. He is active at the national level, certainly active in education at University of Louisville, and has participated in lots to help drive forward care. He's widely published and actually has a couple articles in New England Journal of Medicine, which is high rare air, I'd say. And he's done a great job. I think the key for Dr. Park is that he's really about the humanistic approach to patients and how do you make sure you meet them in that space. And he'll be speaking about the genitourinary cancer updates today. So Dr. Park.
I'd like to thank all the organizers, Dr. Flynn, and everybody for joining us. It's an honor and privilege to be here. And, you know, this GU oncology is so fast-paced. I was in Madrid this weekend and looking at the studies, and we're going to have 4 FDA approvals on the horizon from this weekend, which is pretty amazing. And I'll kind of highlight that. The PowerPoint presentations were actually submitted 2 or 3 weeks ago, but I'll kind of mention what those FDA approvals that are going to be coming our way. Okay, so here's my disclosures. So I want to kind of start out with renal cell cancer update. And there were some updates at ASCO this year on the different studies that are considered standard of care for first line. And so before I do, I want to kind of review for patients with metastatic renal cell cancer, for them to get the best treatment, we have to put them into different buckets. And so the different buckets are intermediate, favorable, and high risk. And it's based upon a clinical and a laboratory features. So for instance, you have clinical features of KPS, which is similar to the ECOG performance status. We also have time from diagnosis to treatment. Now, how do we get there? So if our patients have a surgery for nephrectomy and over a year later, they present with pulmonary nodules and the biopsy comes back as kidney cancer, that's over a year. So that's worth 1 point. And then we look at the laboratory findings. The laboratory findings is more reflective of the inflammatory nature of renal cells. So anemia, increase in calcium, increase in platelet count, and increase in neutrophil count. So if you have 0 of those factors, that's considered a favorable risk. If you have 1 to 2 factors, it's considered intermediate. And if you have more than 2 factors, it's considered high risk. And so Dr. Hang actually broke up the different risk groups based on that plot. As you can see, patients in terms of how they perform with medication is based upon the IMDC criteria. So this is something I do for all my patients. So then the other question is, just like if I was holding a handful of Skittles with different colors, renal cell cancer is very heterogeneous. At one time, if I had a handful of Skittles in my hand, maybe the purple Skittles would be more dominant. But after treatment, maybe it'd be the orange Skittles, because it goes through this clonal selection of natural selection. And so if you look at this study by Dr. Motzer, he discusses all the different mRNA signatures that can occur with renal cell. And so what the take-home message is, if you look at the IMDC and superimpose it to the mRNA, you can see that the favorable risk has a different concentration of angiogenic markers versus immunogenic markers. So if you look at the poor risk on the far right there, there's a lot more immunogenic markers. And so how does that relate to our patients in clinic? Patients that tend to have the highest risk have the more of the immunogenic markers, which tend to respond best to immune checkpoint inhibitors. On the other hand, the patients that are more favorable risk tend to respond more to our oral tyrosine kinase inhibitors. And so with that backdrop, you can see the updated NCCN guidelines. The favorable risk, notice it does not include nivolumab and ipilimumab, because I was mentioning that that's more of a intermediate to high risk. And if you look below at the poor intermediate risk, that's when you have nivolumab and ipilimumab. Now, this is a slide that I borrowed from one of my friends, Dr. Rini. And so what it boils down to for this study is, right now, for patients that are treated by medical oncologists and all of our advanced practitioners, we have 4 options for first-line metastatic clear cell renal cell cancer. And there's pros and cons. On the left, we got the Checkmate 214 with the nivolumab and ipilimumab. And so what are the pros and cons from this busy table? The pro is that if you get a response at 5 years, close to 25 to 30% of the patients have a durable response. Okay. And so they continue to respond well. And this is after stopping nivolumab after 2 years. But on the other hand, it's like when I played baseball at North Hardin High School, okay, if you try to hit a home run, you strike out more often. So if you look at the progressive disease, it's much higher progressive disease. Therefore, if you give nivolumab and ipilimumab and you don't get a response, then the patients can end up with hospice and they might not get to second line treatment. Okay, so those are the things that I look at when I see my patient. I'm more humanistic, like Dr. Flynn mentioned. It's like, if I fail, is this person strong enough to get to second line treatment? If it's no, then I have to do IO-TKI. So on the far end on the right, you look at the CLEAR study. The CLEAR study has two components. You got that TKI, lenvatinib, and you also have the immunotherapy. And notice there on the far bottom there, the progressive disease is much less. And you also have a much more response rate, much higher complete response. And so, but what's wrong with that combination? The combination is it requires a lot of work for the oncologist. This medication can cause diarrhea, hypertension. It requires a lot of buy-in, holding on to the patient's hands, and getting a lot of trust involved. To me, this is the best regimen, but it requires a lot of hand-holding and talking closely with the patients because the toxicities are real. Now, moving on, where is research going in RCC? So as I mentioned, with the nivolumab and ipilimumab, you have that duration and the curve where 25 to 30% of the patients, if they respond, are still alive after 5 years. On the other hand, you can strike out with 1 out of 20 patients where you have progressive disease after 3 months. And then on the other hand, you got the TKI where you have the high complete response and the response rate in the 70%, but you might not have that tail. So the question became, why don't we get the best of both worlds? And that's where the triplet therapy came into play. So the triplet therapy is nivolumab, ipilimumab with cabozantinib. And this was the first triplet that was published and the data was released in the New England Journal of Medicine in May. And so Dr. Churi presented the data, but the problem is it was too much of a good thing. All the patients in this study had a lot more toxicities, and it's all about patient care and quality of life. Therefore, a lot of the patients had to be given steroids. The efficacy of the immune checkpoint inhibitors went down. And so overall, the response rate went down. And so the toxicities based on this study, on the 3 studies there, as you can see, close to 40% of the patients received prednisone. And the question is why? If a patient is on cabozantinib, nivolumab, ipilimumab, and they have diarrhea, as oncologists, we want to try to control the diarrhea right away. We don't know if it's immune checkpoint inhibitor diarrhea or if it's cabozantinib. So what we do is we give steroids and answer questions later. But by doing that, what you do is hypoattenuate the response of the ipilimumab. And so that pretty much summed it up. The only thing I would add to plug our research department, we have an outstanding research department, the best in the whole region. And so I just like to add that we're opening up a first-line renal cell study. I'm very happy that the research study team here, we're going to have a triplet combination of cabozantinib, nivolumab, and relatimumab, which is a LAG-3 inhibitor. Now, relatimumab actually has pretty good data. It was actually in the melanoma study in the New England Journal of Medicine, much less side effects as an ipilimumab, which is a CTLA-4. So we're going to be opening up this study, and I'm very excited for people in this community who have an opportunity for this triplet therapy in our research study. Now we're going to move on to bladder. So the treatment landscape for localized bladder cancer, it's an explosion of data. Okay, as you can see here in 1978, we had cisplatin, and then around 2004, we had gemcitabine, and then in the last 7 years, boom, everything just took off. The first advent was the immune therapy, the immune checkpoint inhibitors. So we had the PD inhibitors and the PDO inhibitors. And then the next thing was the antibody drug conjugates. And so I'll be kind of talking about that. And I'm going to be talking about the EV302 that was released at ESMO 5 days ago. So here's my algorithm for patients with metastatic urothelial carcinoma. This is before ESMO because things have changed a lot. So what I do is whenever I see a patient with stage 4 urothelial cancer, bladder cancer, is I have to determine, are they platinum eligible or platinum ineligible? So the thing that I look for is New York Heart Association class 3. If a patient is walking around, they have shortness of breath, and we have a documented low EF, they're not cisplatin eligible. If they use a hearing aid, they're not eligible for cisplatin. If they have an ECOG performance of 2, not 3, 2 or higher, they're considered not cisplatin eligible. And so then if they're cisplatin ineligible, then I give Dostence MVAC. Then the question is, what do I give Dostence MVAC? Dostence MVAC's got the highest response rate, 65 to 70%. With that said, you have to check an echo. It's for a younger patient population. Cisplatin gemcitabine is about 50% response rate. And then you got the maintenance avelumab. And then you have the cisplatin ineligible, where you have the carboplatin gemcitabine. And then you also have the Padcev and pembrolizumab. And that was FDA approved here. Now, this is where we're going to have 2 FDA-approved regimens that's going to be coming down the pipe for newly diagnosed metastatic urothelial cancer. The first FDA approval that's going to be coming is going to be enfortumab vedotin with pembrolizumab for all comers. The data was stunning. We were in Madrid, it was in Sunday, and everybody just stood up with a standing ovation. And the reason there was such a standing ovation is, as oncologists in GU, nobody's ever seen anything like this. What are the top line data? The top line data is EV with Pembro had a close to 67% response rate. Complete response of 29%. Rapidity of response. The patients responded within the first 2 months. Toxicity profile was very mild. Skin toxicities we have to kind of keep an eye on. So going forward, the new standard of care for all patients with metastatic urothelial cancer will be enfortumab vedotin with pembrolizumab going forward. It's going to be an FDA approved. Now, the second study that's considered practice changing, I consider it like a year or 2 years late, and that is cisplatin gemcitabine with nivolumab. That's also a practice changing study. It had a 20% complete response, but it didn't have the response rate of the 67%, or it was more in the 40 to 50%. So why do I care? If I have 100 patients with metastatic urothelial cancer, I like the odds that 67 out of 100 people are going to respond as opposed to 40-something. So that's why that's the new standard of care. Now, here's the next big shift in urothelial cancer. We have something called antibody drug conjugates. Now, what is an antibody drug conjugate? You get the benefit of the antibody sensitivity to the antigen, but you also get the payload where you can kill the cancer locally, and you have a linker. And so on the left, you have enfortumab vedotin. Antibody binds to TROP2. TROP2 it's in bladder. It's also in skin. That's why we have skin toxicities, but it's much higher concentration in bladder. It's also in lung. So that's what they're doing studies in lung. But this binds to the bladder cancer. Once it binds, you got that strong affinity. It gets endocytosed, releases the toxin MMAE, kills the cancer. Now, we also have sagituzumab govitecan, also a antibody drug conjugate. This binds to TROP2, which is also in bladder cancer. Once it binds to TROP2, releases the MMAE and kills the cancer. And then on the right, we also have ADC. HER2 is picking up steam in bladder cancer. I was talking to one of the PIs for HER2 for bladder cancer this weekend. And, HER2, we have it in for trastuzumab deruxtecan. We have it in breast, Destiny Breast 4. We have it in lung. We have it in esophageal. We have it in colon. Now it's emerging in bladder. And so we have HER2 2+, HER2 3+. We also have something called HER2 1+, HER2 low. And so there's activity with HER2 in bladder cancer. And so this is emerging. So now the FDA approved first-line urothelial cancer, and this is for platinum ineligible, but it will be for platinum eligible coming up soon. And the study for the ineligible was based on the EV103 cohort K. And so strong response here. Patients combination in the cohort A had like a 73% response rate. Cohort K had a 64% response rate. So the take-home message for bladder cancer research is taking off. All of these medications are going in the earlier lines of treatment. I didn't even get a chance to talk about the updated Thor study in phase 3 for erdafitinib with pembrolizumab. It didn't show overall survival, much high response rate. We have to check everybody for FGFR2/3 alterations because that right there is going to move up as well. So now we move on to metastatic prostate cancer updates. So prostate cancer can be very complicated. So what I do is I break up prostate cancer into 5 problems, okay? So the first problem is localized disease. If a patient has newly diagnosed prostate cancer, okay, patients can either receive radiation or cystectomy. Now, after they get radiation or cystectomy, the PSA should be 0 if it's cystectomy. If the PSA goes above 1, we have to consider radiation treatment to the radiation bed, okay? Now, if they have radiation treatment, everybody has a different PSA. Let's say if the PSA goes down to 1.5, if the PSA goes above 2, above that level, that's considered biochemical recurrence. And so the reason I bring that up is we're going to have a new medication that's going to be FDA approved here, and it's based upon the EMBARK study. It was released at the AUA meeting in May. And what does the EMBARK study say? The EMBARK study, and that's what it shows here, enzalutamide for non-metastatic hormone-sensitive prostate cancer. If the patient's PSA doubles in less than 9 months, patients qualify for this medication called enzalutamide, Xtandi, or ADT combination. What it has shown is by doing this combination for a fixed duration for 9 months, patients have disease control rate, disease-free survival for close to 23 months versus 11 months. Because right now, the standard of care here is ADT. And our patients do not like ADT. They don't like the side effects of ADT. So one of the things that's going to be approved here is enzalutamide monotherapy. Now we move on to the non-metastatic castrate-sensitive prostate cancer. That's the second problem that I deal with in my clinic. Patients here are on ADT. Testosterone is less than 50. And the PSA starts going up. We have a lot of FDA approvals there. Right here, this pushes the cancer from coming back to close to 5-6 years. Then we got the third problem, which is hormone sensitive. I call it testosterone sensitive. And then we got the fourth problem, which is castrate resistant. And then we have refractory cancer. Now, one thing I want to kind of highlight in this table before we get into each of these studies is there's still a lot of diamonds in the rough here. For instance, cabazitaxel. Cabazitaxel is underutilized. It works for our patients that go through multiple lines of treatment. It's based on the CARD study. I use it for patients that progress on Taxotere and an AR receptor pathway inhibitor such as enzalutamide, apalutamide within 12 months. That's the sweet spot. You get a great response. Now, here's the question that we have in the prostate cancer world, which is triplet versus doublet treatment. If you look at the NCCN guidelines for metastatic hormone-sensitive prostate cancer, you could either do doublet or triplet. What's a doublet? AR receptor pathway inhibitor with ADT. What's a triplet? Taxane plus AR receptor pathway inhibitor and ADT. That's a triplet. So here's the New England Journal of Medicine article that was released that looked at the triplet study, and it's the new standard of care for high-risk, high-volume patients. And what did it show? It showed a clear separation with improvement of overall survival for our patients. And so then the question is, okay, Dr. Park, you mentioned high-risk, high-volume. What about low-risk, low-volume? What about high-volume, low-risk? And so I made a table here. So high-volume is if you have visceral mets. If the prostate cancer is in the liver or lung, that's visceral. Okay, what about bones? If you have more than 3 bones with 1 lesion outside the spine, such as the pelvis, such as the long bones or the short bone, that's considered a high volume. And then what about high risk? High risk is based upon the Latitude study where they studied apalutamide, and it's based on the Gleason score 8, 9, and 10, and also at least 3 bones and visceral mets. And so the second thing I want to kind of talk about is not all prostate cancer patients are the same. We have something called synchronous and we have something called metachronous. And this is very important because when I talk to my patients with prostate cancer, in my mind, I'm putting them into how long are they going to overall survival? What is their prognosis? And so synchronous. What is synchronous? Patients show up in the ER because of back pain. They have cancer all over their bones. Newly diagnosed prostate cancer, synchronous. What is metachronous? Patients get treated with radiation therapy. They get, the prostate removed. 2 years later, they show up in the ER with back pain. So there's a difference there. That's metachronous. So why does it matter? So if you look at this JCO article here, you look at the metachronous low volume, we're close to 8 years. But if you look at de novo high volume synchronous, it's 3 years. So 8 years versus 3 years is a wide difference, okay? So that way I want to know what the prognosis is when I start talking about treatment. And so this is the practice what I use. I made up this 4x4 table. So if you have synchronous high volume, these patients have the worst risk factors. We have to throw the kitchen sink. AR receptor pathway inhibitor, even though there's 2 level 1 data with abiraterone, with docetaxel and ADT, in that study, that patient population did not include, metachronous. So here you can actually use abiraterone with ADT or darolutamide. Metachronous high volume, you have to use darolutamide. That's the only combination that it was studied, the docetaxel and ADT. Synchronous low volume. So right now in prostate cancer, there is so much data in ctDNA and somatic mutations and germline mutations. So what I do in my practice, because the patients progress much faster if they have these bad actors, and the bad actors that we find on the tissue biopsy, on the liquid biopsy is P53, okay, which is a tumor suppressor gene. So if they have a mutation, that's a bad prognosis. RB1, another tumor suppressor gene, P10, and then BRCA. BRCA is another, BRCA1, BRCA2 is also another bad actor. So even if they have low risk, low volume, if they have these bad actors, these cancers are going to progress. So I do triplet therapy. Now, what about metachronous low volume? We do apalutamide, ADT. That's where the best data is. So here's the NCCN guidelines for castrate resistant. The main thing I want to kind of highlight here is the PARP inhibitors. This is another thing that's kind of really taken off. And so I want to kind of take my time on this. So what is a PARP inhibitor? So to let you guys kind of review, all of us have something called BRCA1, BRCA2 in our body. And that BRCA1, BRCA2 is called a tumor suppressor gene. The purpose of a BRCA1, BRCA2 is if you have any DNA damage, your body fixes it. Okay, so if a patient has a BRCA1, BRCA2 mutation, they do not have a tumor suppressor gene, i.e. they can't repair the double-stranded DNA. So then the question is, what happens if you have a PARP? All of us has a PARP in our body, okay? A PARP is considered a single-strand DNA repair. So that sets up the PARP inhibitor. Cancer cells, if they love to divide and progress, they need DNA to divide and progress. So if they have a BRCA2 mutation, they cannot fix their DNA, which leads to single-strand DNA repair as a backup. Well, if they have a single-strand repair with a PARP and you had a PARP inhibitor, now the cancer cells can't repair its DNA and they become apoptosis. That's called dual synthetic lethality. So that's why patients with BRCA mutation, you give them a PARP inhibitor, the cancer cells can repair its DNA. So there's somatic mutations. 23% of patients have somatic mutations for HRR, homologous recombination. It's a fancy way of saying these enzymes help out DNA, and there's a mutation there. And then you have something called germline that we kind of pass on. 12 to 13% of patients that have prostate cancer have a germline BRCA1, BRCA2. Therefore, everybody that's diagnosed with prostate cancer has to have, and we have a really good genetic staff here at Norton's, everybody with prostate cancer has to have a germline testing with our genetic counselors because they're at risk, their offsprings are at risk for breast cancer, pancreatic cancer, melanoma, and bladder cancer is actually emerging here. And so why do we care? The reason is if we find these patients with BRCA1, BRCA2 mutation, we give them novel hormonal agent, they do much better. So this was at ASCO this year, PROPEL study, which showed that adding a PARP inhibitor actually improved radiographic-free survival. Overall survival is trending. Toxicities and overall response is, much improved there. The main thing you have to look for is anemia. Nausea is something that I've noticed with my patients. And then you have the TALAPRO-2 study, which is another PARP inhibitor, talazoparib with enzalutamide. Talazoparib has a little bit more PARP trapping, which means that it's a little bit stronger into holding that PARP. So you might have a little bit better benefit, but you also have more toxicity. So this combination, you end up with more anemia. And so this is a study here that showed a great response. So right now, I think of PARP inhibitors like immune checkpoint inhibitors in lung cancer. In lung cancer, you have nivolumab, pembrolizumab. We got, different kind of durvalumab. And so in prostate cancer, we have, it's not included, but we have 4 FDA approvals for PARP inhibitors. They're all different. They all have different toxicities. And so the most recent approval is based upon the magnitude study. And I'm happy to kind of highlight our research team. We were one of the highest enrollers for the magnitude study at Norton Cancer Institute. So this is something that really moved the needle and they got the FDA approval here in August. And so what does it boil down to? What's the bottom line? Bottom line is we have to check everybody for germline mutations and somatic mutations, i.e. foundation, i.e. Garden, i.e. Keras. And so if they have a BRCA1, BRCA2 mutation, their overall survival is 19 months. So if they have one of those two, BRCA1, BRCA2, overall survival is 19 months. If they don't have that, it's 36 months. Therefore, if you see these BRCA1, BRCA2 mutations, you have to add a PARP inhibitor because the patients will live longer. And so post-androgen receptor pathway, lot of new information here. We'll kind of go really fast. Vision study, lutetium 617. This was actually presented at PSMA4 presidential session in Madrid. There was crossover in that study. It looks pretty good. I think overall, there's going to be some mixed messages. The difference here is this, and we have a Pluvicto clinic with Dr. Chaw and Dr. Malley and myself. So if anybody knows anybody with metastatic prostate cancer, we have to screen them to see if they qualify for this game-changing medication. But what it boils down to this is this. Patients have to receive 2 medications to get lutetium 177, taxane, docetaxel, AR receptor pathway. On Monday's plenary session in Madrid, they actually did it before taxane. It didn't show overall survival, showed a great response. Bottom line is our patients will not have to receive taxane before getting this medication in the future. And so what's the mechanism of action? Very elegant. You got the antibody, the PSMA 67770. It binds to the PSMA on the prostate cancer. Once it binds, it releases a smart bomb. Now, what do my patients ask me? What is a PSMA PET scan? So I tell them it's a PSA PET scan. Their eyes get really big. Oh, it's a PSA PET scan. Every prostate cancer patient know what a PSA is. And I say, guess where the PSA is coming from? If the PSA is 100, we want to know where the PSA is coming from. That's what the PSA PET scan is. It shows us where the PSA is coming from. So once we figure out where it's coming from, now you have this medication that binds to the PSMA, because the PSA is bound to the membrane, PSMA, kills the cancer directly. 65 to 70% response rate. Last thing, what's the horizon on prostate cancer? Is booming now. I talked about PSMA4. This is very interesting. Breast cancer, estrogen receptor positive breast cancer. We have abemaciclib, palbociclib, ribociclib. It's moving into prostate cancer. That's going to be coming down the pipe. BITE studies. I'm so proud of our research department. Dr. Malley is the leader for a bispecific T-cell engager. This is going to be rising up the ranks for prostate cancer. So if anybody knows of anybody with prostate cancer and they run out of treatments, please consider us for research trial. Bispecific T-cell engager, the way it works is this medication grabs the T cells, takes it to the cancer, and kills it directly, okay? And then we have androgen receptor degraders, very similar to breast cancer. When you have fulvestrant, we know fulvestrant is an androgen receptor degrader. Now there's going to be an androgen receptor degrader. So that's coming down the pipe. You don't have to worry about receptor blockade. You just kill the receptor. And then you have ctDNA, hormone sensitive to ctDNA, castrate resistant. What do I mean by this? I have a patient, because I don't like to let my patients down, right? So I have a patient right now, gone through all the lines of treatment. On initial diagnosis, the BRCA1, BRCA2 is negative, okay? We went through all the lines of treatment. Patient's still strong, wants additional treatment. So I rechecked to somatic mutation, and it came back as a BRCA2 mutation. We started on olaparib based on the FDA approval. Cancer's going lower and lower. The PSA is like less than 10. And then we started at 200-300. So what I'm saying, what's going to happen is these circulating tumor DNAs, you're going to be checking not only at diagnosis, but you're also going to check later, which goes back to what I was talking about, the Skittles. During different points of treatment, because of natural selection, you're going to have different clones of the cancer arise. So for our patients, we have to think about this. I have another patient that's on Keytruda, pembrolizumab, based on the high TMB. Initially, it was low TMB. Now they have a TMB over 200, and they're on pembrolizumab. We have no evidence of cancer. So this is something we have to kind of think about. PARP inhibitors, even though the indication is for BRCA1, BRCA2, based on the literature, PALB2, RADS51, RADS54, there's activity there. All right, thanks.